most important or major hospital in central Kerala. So in such situations, immediately we need to refer and that patient was saved. Now he is fine too, and the neurophysician whom I referred told me if we wait for 7 or 14 days further, sometimes there may be a chance of collapse. So it happens, so we need to refer. And what is the guideline or protocol to be followed in injury and in pathology? I will tell some 1 or 2 cases which we can manage, spinal injuries which we can manage. We have prognosis. We will go through it when we discuss about the case. And in acute injury, we can follow bandage or orthosis. In pathological situation, we can do marma and anesthesia as per the situation and condition of the patient. Rehabilitation should be advised timely in both situations. And in acute injury, we should start the rehabilitation from the very first day. We need to start the rehabilitation. But based on when we are removing the bandage, when we can start moving exercise, based on that, we need to advise rehabilitation in the injury situation. In pathological situation, it is advisable to give rehabilitation after amavajana. If before amavajana we advise rehabilitation, then there is a chance of aggravation of symptoms. So we can start the rehabilitation after amavajana. Then the patient tell us, my morning stiffness is reduced, now I started mechanical pain. That is, we can switch the amavajana medicine to next phase, and also we can start rehabilitation. So today we will give more importance to the applied anatomy of spine because if we need to understand the pathology, we need to know the applied anatomy which is clinically relevant. We need to follow always look, feel and move, inspection, palpation and range of motion, and also we need to have a proper history. So the importance of history taking is 2 things I will tell. In an acute injury of spine, by knowing how the injury happened, we will get a clue regarding the provisional diagnosis. In pathological situation also, if the patient is doing repetitive strain injury, for example, if the patient is continuously doing flexion and extension as part of job, actually there may be a chance of ligamental flavor hypertrophy which causes spinal canal stenosis. So the knowledge of applied anatomy is very, very important in understanding the clinical examination. The knowledge of history taking is very, very important in acute injury situation and in repetitive strain injuries or mechanical low back pain. Another situation, when the patient is telling, I undergone this treatment, but there was no relief. So either we need to avoid such treatments which is not giving relief to that patient. And also if we are continuing the same, then we need to convince that patient. So actually Kalam also gives amavajana. Then next thing I need to tell you, what all things the patient are telling in history, the relieving factors should be advised as pathya, and the aggravating factors should be apatya to that patient. So regarding the history taking, there are a lot of information which we get and also which we can advise. So always give much importance to history taking. I already, in the very beginning of this class itself, I explained a case in which family history was very, very important. So coming to investigations, we need to follow relevant investigations. So investigations is not needed in all cases, but we need to confirm our diagnosis, which we come across with the clinical examination, with proper clinical examination. We need to confirm that with investigation, relevant investigation. And coming to the common differential diagnosis, we should have an idea regarding the common differential diagnosis. And some cases, IG4 related autoimmune disorder, that was the first patient who came to me with IG4 related autoimmune disorder. So in each and every case, we are learning new differential diagnosis, and we should have a knowledge regarding our prognosis. This is very, very important. Why? Because in modern medicine, sometimes in a protrusion, grade 2 disc prolapse, surgical management may be advised. In grade 3 disc prolapse, in extrusion also, surgical management may be advised. In quad syndrome, surgical management may be advised. So we need to know our prognosis. So to get our prognosis, we need to follow our gurus. What I am following is, I will ask my gurus who have about 30 years of experience regarding our prognosis, not by sending MRI report. With MRI report, we cannot assess our prognosis with proper clinical examination, with proper understanding of that case, the pathology of that case. Then we need to discuss with our gurus who have 30, 40 years of experience. They have experience in managing such cases. So we need to interact with them and we get the knowledge about our prognosis in new cases. In old cases which we are managing, we already knew the prognosis. And coming to the chikitsa, it should be based on the dosha and avastha. And if we are following this funnel, then it will be much more specific. So I need to tell you two things. Cervical is more prone to injuries and lumbar is more prone to degenerative diseases. In thoracic spine, there may be more chance of TB. Actually, in the very beginning, I asked about the red flags. If the patient is unable to sleep in lying position, there may be three pathologies. One is infective pathology, second one is inflammatory pathology, third one is neoplastic. And the reason why, because the patient cannot lie down is, if the patient is in sitting position or standing position, the paraspinal muscles will give support. And when the patient lie down, that paraspinal muscle support will be lost, so that there will be periosteal rubbing due to this inflammatory or infective or neoplastic pathology. So in such situations, we need to go for workup. Most probably in these three situations, we need to refer the patient immediately to save that patient. One situation, in some infective pathology of thoracic spine, the first presentation, the very beginning, the presentation of that case will be pain or flanks. At that time, most probably, almost all doctors will do USG abdomen and find out that there is no pathology related to that. In such situations, early investigations in all infective pathologies, early investigations will help the patient, save the patient. At the right time, if we act, then that will avoid paraplegia. So this is actually an axial cut. Axial cut. Axial cut means we are dividing the body into two equal upper and lower parts. You can see this is the axial cut and you can see the body of vertebra here. And this is the vertebral foramen. So here we can see spinous process. This is the lamina. Through the lamina, there is ligamentum flavum. This is transverse process in lumbar vertebra. The transverse process is situated 5 centimeter lateral to the spinous process. And here we can see the superior articular process, which articulates with the inferior articular process of the just above vertebra and forms the facet joint. In lumbar vertebra, the facet joint is situated 3 centimeter lateral to the spinous process. I repeat, in lumbar vertebra, this facet joint is situated 3 centimeter lateral to the spinous process. And in cervical vertebra, the facet joint is 2 centimeter lateral to the spinous process. We can do clinical examination to rule out whether there is facet joint arthropathy. The facet joint arthropathy requires Tikta Rasa Gradas internally after the Amavajana. And this facet joint arthropathy can be clinically examined. This is from the sagittal view or lateral view. Here we can see the body of vertebra. This is superior articular process. This is the inferior articular process which fuses with the superior articular process of the just below vertebra and forms the facet joint. So here we can see the facet joint. Actually, there are two facet joints. Actually, the spine is like a tripod in which the anterior part, the body of vertebra, and the disc forms a joint, and there are two other joints, the facet joint. So that is the strength of this structure. We need to know about pars intraarticularis when we discuss about the spondylolisthesis. So sometimes you can see pars fracture or spondylolysis in MRI. Sometimes patient will come with this diagnosis. Most of the time, patient will come with the diagnosis. And they will, what is your problem? They will say, I have disc prolapse. Or sometimes they will tell us that I have spondylolisthesis. And in spondylolysis, they will come and ask, I have spondylolysis, what I need to do? Actually, spondylolysis is the purvarubam of spondylolisthesis. So actually, I need to ask you one question. You can reply in chat box. I need to ask uh, which exercise may be good for almost all spinal conditions? Flexion exercise or extension exercise? Most commonly, we are be in flexion position. Most commonly, we are in flexion position. So basically, which exercise may be good? Most of the people are sitting. Or I will ask you which exercise may be good for an IT professional, flexion exercise or extension exercise? Or which exercise may be good for a person who is following rituals in a temple, a pujari, which may be good? You can send me a message in chat box. Okay, extension exercise is good, very good. Extension exercise is good. So extension exercise is good. Thank you for the answers. Actually, it is a right answer. Extension exercise is very effective for almost all spinal situations. But in spondylolisthesis and spinal canal stenosis, you may write down this. In spondylolisthesis and in spinal canal stenosis below 10 mm, it is better to avoid extension exercise. Extension exercise. So when the patient climbs up, there is pain relief. There is pain relief. And in another situation, the patient is climbing down, there is pain relief. So these are two situations which we need to differentiate. When the patient climbs up, the patient is in flexion. So when the patient climbs up, if the pain is increasing, means it is due to neural foraminal stenosis. When the patient climbs down, patient is coming down in extension. If the pain aggravation is there, it means it is due to spinal canal stenosis. So whenever there is spinal canal stenosis below 10 mm and in spondylolisthesis, we should avoid extension exercise. So in spondylolysis also, when the patient came to ask us, I have spondylolysis, then also we need to avoid extension exercise. So we should give rehabilitation, but better to avoid extension exercise. So we need to know what is spondylolysis. Actually, spondylolysis is the fracture of pars intraarticularis, and pars intraarticularis is the area where the superior articular process and inferior articular process fuses. I repeat, in all vertebra, we already discussed about the facet joint, which is the articulation of the superior articular process and inferior articular process. So when the superior articular process and inferior articular process of a single vertebra fuse, that area is pars intraarticularis. And whenever there is fracture of pars intraarticularis, it is known as spondylolysis. And spondylolysis is the purvarubam of spondylolisthesis. So we can see a central nucleus pulposus which is hydrated and it is surrounded by annulus fibers, and the central nucleus pulposus starts degeneration initially, and it is known as disc desiccation. Desiccation means dehydration. You can see in MRI there is disc desiccation. Desiccation means dehydration. And through this desiccated central nucleus pulposus will migrate through the annulus fibers and it comes out. First, it touches the posterior longitudinal ligament. I will show what is posterior longitudinal ligament. And whenever the posterior longitudinal ligament, I will show one image that is, you can see through this, there is anterior longitudinal ligament. Anterior longitudinal ligament is connecting the disc and the anterior part of body vertebra. The posterior longitudinal ligament is connecting the posterior aspect of the body of vertebra. But this posterior longitudinal ligament is anterior to the spinal canal or vertebral foramen. So initially this touch the Posterior longitudinal ligament. And this posterior longitudinal ligament is strong at cervical, and it when comes down through the lumbar area, it tapers. So, apart from central disc prolapse or posterior disc prolapse, posterolateral disc prolapse is common due to this posterior longitudinal ligament, and this posterolateral disc prolapse causes neural foraminal stenosis. And second thing, this when it comes to the lumbar area actually it tapers down, and that is the reason for more disc prolapse at lumbar area. So this is the sagittal view of central nucleus pulposus and annulus fibers. And whenever there is dehydration of the nucleus pulposus, which is hydrated, it is known as disc desiccation. So here we can see the axial cut, central nucleus pulposus and surrounded annulus fibers. And whenever there is a tear in annulus fibers, in that situation also it is painful. When this touch the posterior longitudinal ligament, it is also painful. And second thing, here we can see the lamina. Through the lamina, ligamentum flavum is connecting. And here we can see the neural foramen. This is the facet joint and parts. We already see the parts in another view or coronal view. Here we can see the parts. Actually, whenever there is facet joint arthropathy, it causes neural foraminal stenosis. Whenever there is posterolateral disc prolapse, it also causes neural foraminal stenosis. And also, whenever there is the posterior body of vertebra osteophyte formation, the osteophyte formation of the posterior body of vertebra, that also causes neural foraminal stenosis. Whenever there is central disc prolapse, or direct posterior disc prolapse, then there will be spinal canal stenosis. Whenever there is ligamentum flavum thickening, then also we can see spinal canal stenosis. So this is the anterior longitudinal ligament, and this is the posterior longitudinal ligament. Please note, posterior longitudinal ligament is anterior to the vertebral foramen, but posterior to the body of vertebra. And here we can see the intertransverse ligament, supraspinous ligament, interspinous ligament, and facet capsular ligament. Actually, whenever we are giving rehabilitation to spine, we are giving strength to these entire structures, which will help the patient to be in normal alignment. And also this rehabilitation helps in proper circulation, proper functional outcome will be better if the patient is continuously doing rehabilitation with proper postural correction and activity modification. Coming to the basic clinical examination, there are some situations in which there will be increased lumbar lordosis and there will be loss of lumbar lordosis. I am not asking you to send messages for this answer, but you may just think in which all situations there will be increased lumbar lordosis. One or two situations you just keep in mind. You can just write down and just imagine some situations whenever there is loss of lumbar lordosis. And in the beginning, I think I explained a case regarding IG4 related autoimmune disorder. And I explained one case, mechanical back pain, in which rehabilitation was only the advice to that young boy, and he get rid of that pain. Another situation I explained with severe radiculopathy, L5 nerve root radiculopathy, who came to OPD with the support of his friends on both sides. You can also write down one prescription for him. He has severe morning stiffness. At that time, there was severe morning stiffness and it was unable to get up from bed, need much more time. Usually he was an IT professional. And second thing, he has typical L5 radiculopathy and he was unable to stand for 1 minute. When he stand for 1 minute, there was severe aching pain in which he need to sit. And getting down from car, standing after a small time means when he sit for 15 or 20 minutes, it was unable to stand from that position without another person's help. That was the presentation. There was night pain too. The patient was unable to sleep at night. On rollover also there was pain. It was the presentation. So you can just think about some medications in which the patient will be fine within 2 days or 3 days. You can plan some anesthesia procedures like SandhiVeda, which help the patient. Or you can select some Sweda procedures or some procedures which is very cost effective, like Avagaha Sweda. You can think about such things also. So just think about that situation. So coming to the situation where increased lumbar lordosis in listhesis, which we are avoiding to do the extension. Pregnancy in one class, one of the senior medical officer who attended that class asked me, actually, the increased lumbar lordosis at time of pregnancy was not back to normal position, whether it's possible to regain that position with the help of rehabilitation. That was the doubt. Uterine fibroid and all hip diseases, Perthes disease, CDH or DDH, developmental dysplasia of hip. In all these situations, there will be increased lumbar lordosis, all pathology related to hip joint. So vice versa will also happen in listhesis. In listhesis, sometimes the patient will present to us with hamstring pain due to the difference in gait. To overcome that increased lumbar lordosis, there will be pain over hamstring. Such situations may also happen. In avascular necrosis, most of the time the patient will present to OPD with medial thigh pain. So such situations may happen. And in another situation, in shoulder joint, when we discuss about shoulder joint, we will discuss to strengthen the right shoulder, which muscle we should focus the most for a javelin throw, athlete or a fast bowler, right arm fast bowler, like Bumrah, which muscle is to be kept most patent. So coming to some situations where loss of lumbar lordosis in IVDP or PID, prolapsed intervertebral disc, infections of spine, ankylosing spondylitis, lumbar spondylosis or cervical spondylosis, in which we can see loss of lumbar lordosis. Due to significant muscle spasm also, there will be loss of lumbar lordosis. We can go through some basic clinical examination which we all knew. Straight leg raising, we need to always look on patient's face, and I need to tell you one thing. Active SLR, we are checking active SLR to check the patency of the extensor mechanism of knee joint, flexion of hip joint, and also in sacroiliitis, we can ask the patient to do active SLR. When we need to check the radiculopathy, we should do passive SLR. Passive SLR should be followed to check regarding radiculopathy, and always look on patient's face. And whenever in a situation we can see pain, at the time we need to lower that leg, and then we need to do the dorsiflexion of the foot. I repeat, whenever we see pain in patient's face, we need to lower that straight from that position where pain happened. We need to lower, and then we need to do the dorsiflexion of the nerve roots to confirm whether it's a radicular pain. So the typical feature of radiculopathy is sharp shooting electric shock like pain, which passes through the affected dermatome, which aggravates with activities and relief with rest. This is the typical feature of radiculopathy, sharp shooting electric shock like pain through the affected dermatome, which aggravates with activities and relieves with rest. In all situations when regarding spine, whenever there is pain or rest and that pain is not subsiding with rest, the pain is aggravating with rest, is actually a red flag. And actually flip is seated SLR. Actually it is to be done passively. We need to extend the knee joint in tilting position. At that time, due to severe pain, this can be done in active extension of knee joint can also be done. Whenever there is radicular pain, typically the patient needs the support of both hands to sit due to severe pain. So this is the typical feature of positive flip when we are extending the knee joint. Due to severe pain, patient needs the support of both hands. They will support our back with both hands. This is the typical feature of flip. So I think I added some videos in YouTube. You can search in YouTube with my name. You can see some situations where flip is positive. And in that situation, in that case, that's actually a extrusion case with severe radicular pain. which was not responding to conservative management. And in that situation, we done Rektamoksha Siraveda from Andara Kandara Gulfir Andare from the posterior tibialis vein. And actually, he got relief. He got immediate relief, and flip was possible to done immediately after the procedure. In indicated situations, we get around 50 to 75% pain relief with this Siraveda. So we need to follow the Purvarma and Paschat Karma correctly. We need to give Sadhisneha before one Muhurta before the procedure. And if we need Uttana Siddha, for Uttana Siddha, we need to give local Snehaswada to that angle part. And we are doing the Siraveda from the affected leg, radicular affected lower limb from Andara Kandara Gulfir Andare. And after the procedure, we need to protect the Vayu and Agni. Solute replacement should be ensured to avoid complications after Siraveda. So the Purvarma and Paschat Karma should be safe in all situations to avoid complications. So it is possible to get rid of this pain immediately with this procedure. Coming to femoral nerve stretch test, it is actually we are checking the upper lumbar L1, L2, L2, L3, L3, L4, all this flip, SLR, braggarts, which we are doing for L4, L5 and L5S1. Whenever there is pain below knee, or the medial aspect is due to L4, or the lateral aspect, and towards the big toe it is due to L5, and the lateral toe and heel S1. One of the typical differential diagnosis of plantar fasciitis is S1 nerve root lesion, and actually in that situation also Agni Arma is found to be effective. If we do Agni Arma, there will be pain relief. Without knowing the pathology, without having good diagnosis, without having the specific diagnosis also, then we get relief. Actually, our Acharya helped us a lot in these situations. And in FNST, femoral nerve stress test, we need to check this like in this position. Actually, in prone position, the patient should be in prone position and flex the knee up to 90 degree. And then we need to extend the hip. There will be pain over the anterior thigh. This is FNST. We can do the same FNST in lateral lying position and also in standing position also it is possible, but rarely. If we manage 100 cases of L4, L5 and L5S1, 2 cases will come with upper lumbar. When there is upper lumbar lesion also, we are doing the Siraveda from same side. Actually, Acharya Susruta is explaining Siraveda 4 angula above Janu and 4 angula below Janu. The 4 angula above Janu can be opted for this upper lumbar radiculopathy, but I am doing Siraveda from Andara Gulfir Andare itself in upper lumbar lesion also. There will be also relief, but that situation is rare when compared to L4, L5 and L5S1. But we need to do this clinical examination to rule out whether there is upper lumbar lesion. And hip examination is very, very important in differentiating a shoulder pathology and cervical pathology, differentiating a hip pathology and lumbar pathology. This is very, very important in assessment of prognosis, medicines and prescription, when we advise rehabilitation, in all these things. Sometimes there may be a patient with lumbar radiculopathy and avascular necrosis. It may happen. So always never be contented with our diagnosis. Always check multiple times to have a clear-cut diagnosis. And what I need to tell you, if there is a patient with a shoulder pain, so we need to check the Upley's scratch test. In Upley's scratch test, what we are doing, the internal rotation of the shoulder, we are touching the opposite scapula, inferior border or body of scapula. We can check the abduction and external rotation. We can touch the opposite spine of scapula, and then through this position, adduction and internal rotation, again we are touching the body of scapula. This is Upley's scratch test. Whenever a patient comes with a shoulder pain, within 10 seconds we can check the Upley's scratch test. And with Upley's scratch test, we can differentiate if both three position the patient can attain, then it is not due to shoulder pathology, it is due to cervical pathology. So one of the most common cause of shoulder pain is cervical pathology. So we need to differentiate it. And in hip joint also, I already advised, the patient most commonly with AVN may present a medial thigh pain. So We need to check the hip examination in sitting position, supine position, and prone position, and in which prone position will help us to diagnose AVN at the early stage, diagnose quality of life of that patient. So I will explain three situations in avascular necrosis of hip joint. Why? Because in X-ray, the changes may come late. MRI can be used for early detection. After doing the clinical examination, and after confirming the provisional diagnosis for the confirmation, we can use this. Second thing is ankylosing spondylitis. In ankylosing spondylitis also, it is very, very important to ensure the quality of life and life expectancy. We need early diagnosis in which we can advise MRI before taking X-ray. Sometimes Romanus lesion or shiny corner lesion will be positive in ankylosing spondylitis, and almost in all spondyloarthropathies, it will be positive and we can rule out it at the earliest. The third situation is osteomyelitis or infections, in which the X-ray may take much more time. We can check MRI. So three situations. One is ankylosing spondylitis or spondyloarthropathy. Second one is avascular necrosis of hip joint. Third one is infections or osteomyelitis. So we can prescribe MRI before advising X-ray. So you can have a look on this picture. Out of this, which one is the internal rotation of the hip joint, first one or second one? Which is the external rotation of the hip joint, first one or second one? Actually, this picture, the first picture is the internal rotation of hip joint in sitting position. Second one is external rotation of hip in sitting position. Don't be confused. Actually, this is internal rotation of hip in prone position. 35 degrees is the normal. This is external rotation of hip joint in prone position, because in neutral position, in supine position, we are checking the internal rotation and external rotation of hip in sometimes most probably in 90-degree flexed hip joint. Here we are checking the internal rotation of hip in neutral position. So this position definitely helps for early detection of avascular necrosis. So sometimes we suspect avascular necrosis. We need to check the internal rotation of hip in prone position. We can check both sides and check whether one is affected. I already explained look, feel, move, inspection, palpation, and range of motion is the basic clinical examination of almost all orthopedic or musculoskeletal pathology. And second thing, always we need to do the clinical examination in normal joint first. So always compare when we are assessing range of motion, when we are measuring, always compare whether there is any difference with the opposite limb. So sometimes due to injury, due to a fracture, or due to any injury, most probably unilateral AVN will present. But due to some other situations, pathological situations, like due to some other autoimmune disorder, or due to steroid, or due to excessive alcohol intake, in such situations, bilateral hip will be affected. So we need to check both the hip joint. So please note, this is the internal rotation of hip joint in prone position, and always practice this to detect early avascular necrosis, which definitely help the patient. So this is actually heel walk. In heel walk, we are not assessing pain. In heel walk, we are assessing the power, whether the patient can do heel walk for 10 steps, and the power is 5 by 5. Actually, we are checking heel walk for L4, toe walk for S1, and definitely for extensor hallucis longus EHL. Extensor hallucis longus weakness is checked for L5. I repeat, for L4, we can check heel walk. For S1, we can check toe walk. And for EHL, extensor hallucis longus, the big toe extension is checked. The power of big toe extension can be checked for L5 nerve. So here we can see a video of toe walk is affected here. You can see the patient is unable to do toe walk. So most of the time, I think some of you may have experience in managing some cases, spinal canal diameter of lumbar below 5 up, below 5 up. One of my friends, one of my colleague who was doing MD, he's now assistant professor in one of the major institutions in India. And once he made a call, we have good discussion. That is very, very important thing in growing. Always we should grow in groups. An individual, if try to grow, there will be a limit. So I have we the PG mates of that particular era when we were together, we have good discussions. All our practitioners are doing good discussion. And once he discussed a case with spinal canal diameter below 5 mm, and he asked me how we are assessing this. Actually, surgery is advised. So we are avoiding that surgery in that patient due to patient's fear of surgery. So actually, we can check this heel work and toe work, heel work and toe work. And actually, this is another situation. This is for cervical compressive myelopathy case, in which you can see there is flexion of the thumb. You can see in this, it is very, very visible. Actually, the flexion of thumb is there. This is actually Hoffman's sign. You can see there is flexion of thumb when we are tapping the middle finger. See, there is flexion of thumb and flexion of the index finger. Once again, I will show you. Actually, this is a typical feature seen in check. You can see there is flexion of thumb. See, this flexion of thumb is seen. Actually, this clinical examination, Hoffman's is same like Babinski. And whenever there is a compressive myelopathy at C5 or C4 or in cortical lesion also, this sign will be positive, Hoffman's. Actually, this patient, this patient, the Hoffman's positive patient, started symptoms 9 months ago. 9 months ago, he felt weakness of lower limb and he is actually working in a press, unable to hold materials and walk. There is loss of balance due to compressive myelopathy at C5 level, and he undergone surgical management for the same. And after 6 months, there was no relief. After the surgery also, there was no relief in symptoms. In 50% cases, it may happen. In 50% cases, it will be successful. In cervical compressive myelopathy cases, it is tough for a good relief. Actually, that patient came for me with same symptoms, same before surgery and after surgery. So in this, and on second MRI, after the surgery, second MRI, it was normal. MRI was normal, there was no disc prolapse. In MRI, on sagittal view and axial cut, there is no disc. But the patient has all symptoms after the surgical management. So for cervical, just like L4, L5, L5, SLR and flip test, in lower cervical, we can do this Sperling test in which we need to check the extension and lateral flexion or lateral rotation. Extension plus either rotation or extension plus lateral flexion can be checked, in which there will be radicular pain while doing this procedure. And if there is severe pain, today one patient came with severe cervical radiculopathy, in which he has C6 nerve is affected. He was advised to follow surgical management from 2 hospitals. Actually, one patient is admitted here with radicular pain. C5 nerve is affected. Due to in both these cases, Sperling test is positive. Sperling is positive. So we can assess this Sperling test, but do it gently. And coming to the differential diagnosis, this is actually regarding the cervical spine. Cervical spine due to the postural error due to the use of gadgets as part of job, or in present era, so many people are using much more screen time. There may be Textnung disease. Textnung disease is actually from the spine. the muscles which are attaching to the middle border of scapula will be much more tight. When the patient is doing 10-degree flexion of cervical spine, there will be 6 times load. And whenever there is 20-degree flexion of cervical spine, there will be 12 times load. So there will be textile disease. In textile disease, the presentation, most commonly the patient will come to us in between 20 to 24 without any radiological finding. Severe pain will be there. Movements will be normal in the initial phase. The second phase movements will be affected. And actually, what is the problem in textile disease is there will be early degenerative disc disease. There will be early cervical spondylosis due to the mismanagement, due to the lack of management at proper time. So it causes scapular pain, and actually it is a vicious circle. It will affect the movements of shoulder joint also. In the later phase, actually, there will be postural error associated with the patient will complain, I have difficulty in breathing also. Breathing also, it will be affected. The postural muscles are tight, anterior muscles are weak. So it should be go in hand, and some muscles need stretching, some muscles need strengthening. So the muscles which are not working also causes problem. And the tight fascia. So in these situations, marma has a good role. We need to do marma and release the fascia, release the pain, and then the patient need to correct the posture and do the rehabilitation. So coming to the low back pain, we can divide basically low back pain into 3. Actually, this is from Matre. From the very beginning, I already advised actually understanding these situations make us more proficient and efficient. So we need to tell, you need to follow this thing in this much days, this will happen, this much recovery will be there. In some situations, we need to tell at the very beginning, in the initial consultation itself, you need to follow some management like Snehavana, or you need to follow some management like Vasti. All these things we can do in the first visit or on the follow-up visit if we are following this protocol. And it was taught to me by my gurus. Each and every word which I am telling in this class was taught to me by my gurus, and still they are teaching me. And anything which I am telling wrong in this class is by me. And coming to the low back pain, it can be divided into 3. One is referred pain, it is from Makre. Second is true back pain, which is again divided into division of 3, and malingering. So malingering cases also come almost 10% to 33% patients may come with malingering. So we need to know whether this is malingering also. Sometimes there is a situation known as functional overlap. Some patients will tell us, due to this work, what I am doing for this much years, I have pain. So they are telling like that. And referred pain means due to some other pathologies like genitourinary disease, or maybe due to calculi, or maybe due to pancreatitis. So this is regarding referred pain. So we need to know the differential diagnosis of that thing also. In some cases, there may be a chance of referred pain. Sometimes in cholecystitis, there may be a pain over the shoulder tip. So such referred pain we need to know. And true back pain we will divide into 3, I will tell, and malingering. There are some clinical examination tests like Hoover's sign, in which we are doing the passive SLR and we are checking whether the opposite limb is pressed down to the couch when the patient is doing this passive SLR, because the passive SLR causes pain, and the opposite limb, definitely it will be much more pressed down to the opposite couch. So we can always look. Why? Because each and every person know SLR is the primary test for checking low back pain. So always, most of the time, some people will come with malingering, and we need to differentiate it. These are some of the causes for referred pain. And the division of 3 regarding true back pain, the first one is spinal pathology, like vertebral infections or ankylosing spondylitis, tumors, listhesis, spondylosis, or osteoporotic spinal fracture without any history of fall. And nerve root pain, which we are more focusing, prolapsed intervertebral disc and facet joint degeneration are the causes for nerve root pain. And the third one of true back pain is disturbance of mechanical back pain. So, we need to check all other differential diagnosis And after checking all other differential diagnosis, and we are rolling out all other differential diagnosis, and then we come to the conclusion that it is mechanical back pain. And in mechanical back pain, actually, it comes almost 25% to 33% mechanical low back pain. In that situations, rehabilitation exercise is found to be very effective. In that cases, postural correction will definitely help the patient. In these situations, disturbance of mechanics, when we are doing the external SandhiVedas, it is found to be effective. In mechanical back pain, the all other people that quacks who are doing some manipulations or some remedial things which is found to be effective in mechanical back pain cases. So in other situations, we need to focus. So we can go through some cases and then we can discuss about the management protocol. I'm telling about the protocol. Actually, one single medicine won't give us any result. So two things I need to convey. One thing, if the patient is telling us a particular relief on a medicine, on a protocol which we are following, then on getting that relief, we need to switch to the next protocol or next medicine. So we need to follow that thing. And this is a common situation, sudden giving way on lifting weight, sudden giving way on getting up from bed. There is severe pain. There was history of recurrent attack. The patient traveled a lot in a two-wheeler to Kodaikanal. And then coming back to home, he was just unlacing the shoes. Immediately he felt severe pain. Yeah, sometimes the patient's weight will be nearly 100 or 90. So this is one situation. Another situation in which it may be sometimes a 32-year-old lady who has 1-year-old child who undergone a normal delivery on doing some activity in kitchen on sudden movement on the from the flexion she was doing extension, there was a sudden severe pain. So this is another situation. Sometimes a normal man who was doing some activities in home which he was not familiar with, why? Because he is doing some office job, and on the seventh day, on the off day, Sunday, he was doing some activities which he was not following every day. At that time, there was a severe pain. And some patients will tell us, actually, I have a pain 3 months back, sudden severe pain, when I was doing one activity. And I took 2 days rest. I applied some balm, I took a painkiller, or I took painkiller injection. It got rid of. There was pain only to low back area. I was doing some activity 1 week back. It was a different activity from 3 months back. But anyway, I was doing this. I have a sudden severe pain, and now I have a electric shock like pain towards my lower limb up to ankle joint. Sometimes patient will tell us like that. The first situation was only a disc prolapse. Just the disc prolapse started, or just there was an annulus fiber tear, or just the disc touched the posterior longitudinal ligament. It subsided within 2 days or 3 days. Even if it was not done anything, any management was done, it will be subsided in 2 to 3 days. But on the second time, there was radicular pain, nerve root pain, neural foramen stenosis was there. So in these situations, we should know the differential diagnosis. So sometimes it may be disc prolapse, which we can diagnose with SLR and flip. Sometimes there will be annulus fiber tear, or just this touch the posterior longitudinal ligament. Sometimes there may be muscle strain, in which most probably the patient complains pain over the lateral area of lumbar spine. Most probably it may be either QL or iliopsoas. And the last one is ligament sprain of the sacroiliac joint. Ligament sprain of the sacroiliac joint. There is anterior and posterior ligaments over the sacroiliac joint, and that ligament sprain also causes pain. In this situation, all these four situations we should immobilize. Immobilization is the best thing in an acute situation. In an acute situation, I am telling that it can be divided into subacute and chronic. In chronic situation, never do immobilization. The first thing in all acute situation, the best thing is to immobilize, but we should know how much days it should be immobilized. In a lumbar disc prolapse, we can immobilize for a period of 7 days or maximum 14 days. Most probably, we can remove the bandage at the earliest. We can do a hip spica bandage or we can use LS Coser. In annulus fiber tear or just the posterior ligament is touched with degenerated disc or that desiccated disc, there is no need of bandage. In muscle strain, we can bandage for 2 days or 3 days. In ligament sprain, we can do the bandage for 3 days or 5 days. That much time frame is needed. So this is actually the first one is the disc starts to herniate. Second one is protrusion. Third one is extrusion. Last one is sequestration. Sequestration means a piece is dislodged into the spinal canal. Actually, it is surgical. That situation is surgical. We always need to have this picture in mind. A posterolateral disc prolapse causes neural foraminal stenosis. Facial joint arthropathy and osteophyte formation of the body of vertebra also causes neural foraminal stenosis. But the pain due to this disc prolapse is much more severe when compared to the osteophyte formation. Ligamentum flavum thickening or hypertrophy of ligamentum flavum also causes spinal canal stenosis. Those who are continuously doing flexion and extension as part of their job, they met with the ligamentum flavum hypertrophy. Whenever there is central disc prolapse, it causes spinal canal stenosis. So we need to differentiate this extrusion from protrusion. So actually, this Thompson's test is a good test. Thompson's test is patient is in prone position, flex the knee up to 90 degree, and we should do forceful dorsiflexion of the ankle. I repeat, patient is in prone position. We need to flex the knee up to 90 degree, and dorsiflexion of the foot causes severe radicular pain. In extrusion, in protrusion, it won't be much severe. So we can see the protrusion actually here. This is actually sagittal view. We can see the nucleus pulposus is normal. Here it is desiccated and there is a protrusion. And here we can see the difference between extrusion. In extrusion, the dislodged material is much more. I will show you another picture. Actually, see the shape of normal disc. This is an axial cut. Here we can see ligamentum flavum. This is the facial joint. Here you can see a bulge, protrusion. And please note that actually this is the left neural foramen and this is the right neural foramen. Just think the patient is lying before us in supine position. This is the left and this is the right. So here we can see there is right neural foramen stenosis. And in extrusion, the dislodged material is much more, which is compressing. So what is the difference between protrusion, second stage and third stage? You can see in extrusion, this space is much more. That means in protrusion, the bulged or herniated area is more. But in extrusion, that this distance, the total distance from the herniation is much more than the herniated area. So this is the difference between extrusion and protrusion. And also sequestration is actually, it is separated and dislodged into the spinal canal. In extrusion, you can see in MRI there is caudal migration or cephalic migration. Actually, migration is not sequestration. Migration means it will migrate, that extruded material will migrate either to caudal or cephalic. Sequestration means it is dislodged into the spinal canal, which is actually requires surgical intervention. You can see the difference between extrusion and protrusion. And the second one is a history of fall.
Dr. Gikto, sorry for disturbing. Other than MRI, is there any way we can differentiate between the protrusion or extrusion or sequestration?
Yes, actually, I already explained in extrusion, we can check the Thompson's test to differentiate it with protrusion. And regarding sequestration, it is needed to better take MRI if we suspect. So in sequestration, I will discuss some other clinical examinations, there is some situations like food drop or saddle anesthesia. Saddle anesthesia means the perineal numbness, and then in another situation, food drop, saddle anesthesia, and when there is bowel bladder incontinence, we can suspect a sequestrated disc material in the spinal canal.
Okay, wonderful.
So
Thank you.
with these clinical examinations and with the clinical features, we can suspect. But for sequestration, actually, it is better to take MRI. But protrusion and extrusion, we can differentiate clinically and with clinical examination. And coming to second case, actually, this is a case. Actually, she was a teacher, and she was at home. When one of the guests came to her home, she was doing something in kitchen and she had a fall on sitting position. Actually, it is a flexion injury. Actually, we can divide spinal injuries into 7 basically: flexion injury, flexion rotation, vertical compression, extension, flexion distraction, direct injury, and indirect injury due to violent muscle contraction, in which this is the commonest one, flexion injury. And more commonly, there will be a fracture, wedge compression fracture to T12 or L1. Sometimes T11 will be there. So in this situation, we can do the clinical examination. Before taking the X-ray, we can check, just tap the spinous process. We can tap the spinous process. Actually, this is a situation with pain, severe pain. We can tap the spinous process in which there will be severe pain. So we can check the thoracolumbar X-ray, epi view and lateral view. So we can see the wedge compression fracture, In this situation, either we can do a vibandha bandha, like this, or we can use a thoracolumbosacal corset. Either we can do a vibandha bandha, in which we should pack cotton over the spine, and we can pour Muruvana also, or we can use a thoracolumbosacal corset. Actually, in this situation, complete rest is very much needed in the initial phase. One of my professor told me one case. He managed a case of one minister of state government, Kerala, in which that minister was taking complete rest for 45 days completely, and actually he told me that wedge was reduced on taking this complete rest. So if the patient is following rest properly, then the recovery also will be good, and then we need to give rehabilitation exercise as per the age of the patient, as per the health of the patient, and based on the pain relief. We need to start the rehabilitation. So in this situation, in an acute injury situation, it is better to give internally Mustadi Marma Kashaya in the initial phase, or Punarnavadi Kashaya in the initial phase. And in the second phase, we can opt Dandodhana Kashaya internally. And in the later phase, we should give internal Sneha. At the time of rehabilitation, we can opt internal Sneha, and also at that time, it is beneficial to do Matra Avasti. Actually, it is advised in Kadi Bhakna in Susruta Chikilsa 3rd chapter. And also in Bhakna Anandara Kriya, at the time of rehabilitation, Matra Avasti or Sneha Avasti is advised. So it is better to opt at the time of rehabilitation. We can opt the Anandaram, Thailam Meduku Bhagam can be taken for that. And also in at the time of rehabilitation, after the functional outcome, it is better to opt in Asti diseases or the Ubadadu of Asti diseases in fracture, and also in some other pathologies related to Asti. In that situation, we can opt internally Krishna Tila or Gandha Taila as Rasayana. At the last phase, along with rehabilitation, the patient can take Gandha Taila as Rasayana to in injury situation. This is another situation with injury. I already explained in the very beginning. We can have a discussion on some acute injury situations which we have prognosis in spinal injury cases. And this was an RTA. Actually, this was happened to one of my friend. Actually one lorry overtake his bike and he met with this injury. And that lorry driver doesn't stop, and I think the driver may not know that he hit this bike on overtaking. And actually there was severe pain and he was unable to stand straight. And in this situation, actually Neymar also met with this injury, indirect injury due to violent muscle contraction. Due to the pull of iliopsoas muscle, multiple transverse process of lumbar vertebra will be fractured. Actually, I already explained it when we explained the applied anatomy. From the spinous process, 5 centimeter lateral is the transverse process and 3 centimeter lateral is the facet joint in lumbar spine. So, in X-ray also it is visible. Due to the pull of iliopsoas muscle, multiple transverse process of lumbar vertebra will be fractured. Here, this is a CT. So, in this situation, complete rest is needed. We can opt hip spica bandage based on the age of the patient, based on the pain relief. Actually, we need to take rest for a period of 3 to 6 weeks. And here, if we are not using a hip spica bandage, we can use a controlled LS corset. Can be used. Complete rest is needed. Here also, after the initial management with internal Punarnavadi or Mustadi Marma Kashaya, in the later phase, we can go with Dhanudara Kashaya. And in this situation also, at the time of rehabilitation, it is better to opt Dhanudara Thaila Medugubagam Matravasti. So coming to the next case, in which the patient is unable to stand for 2 minutes. Actually, there is not much morning stiffness. When the patient stands, it is not possible to stand for a while due to severe radiating pain to lower limb. And when we do the clinical examination, actually there is a step at the lower lumbar region. And the oblique crease seen over that area is changed to a transverse crease on inspection. So here we can have this diagnosis of spondylolisthesis. Actually, this is a lateral view X-ray, lumbar lateral view X-ray. When we are taking lumbar lateral view X-ray, we can see there is spondylolisthesis, and here you can see spondylolysis. I already explained spondylolysis is the pururubum of listhesis. Here you can see the spondylolysis fracture of parts. And regarding the grading of spondylolisthesis, actually whenever there is 1/4 displacement, 25% displacement, it is considered as grade 1. 25% to 50% considered as grade 2. 50% to 75% considered as grade 3. 75 to 100, it is grade 4. Up to grade 2, conservative management is possible. Conservative management is safe. Grade 3 and grade 4 is actually surgical, but in grade 3 situations, we can check the clinical features of that patient. And based on so many factors like comorbidities, obesity, age of the patient, we can try for conservative management in grade 3 based on multiple factors. So in lateral view X-ray, we can diagnose the spondylolisthesis. Before this X-ray itself, we can get the clinical examination, and one of the typical features of spondylolisthesis is there is pain over extension. In spondylolisthesis, there will be pain over extension, and we should avoid all extension exercise in spondylolisthesis. We already discussed this applied anatomy, and this is the pars intra-articularis, in which the superior articular process and inferior articular process of a single vertebra meet, and the fracture of pars intra-articularis is spondylolysis, and whenever there is displacement, it is listhesis. And in oblique view X-ray, in cervical spine, we are taking oblique view X-ray to rule out neural foraminal stenosis due to facet joint arthropathy or due to the posterior osteophyte formation of body of vertebra. I repeat, in cervical spine, we are taking oblique view X-ray to rule out neural foraminal stenosis. In lumbar, we are taking oblique view X-ray to rule out whether there is spondylolisthesis. And we can see in normal oblique view X-ray, we can see this Scotty dog D terrier sign. And whenever there is a ring around the neck of the Scotty dog, it is spondylolysis. And whenever there is Scotty dog decapitation sign, the head is cut off, it is seen in listhesis also. So this oblique view X-ray help us to diagnose spondylolisthesis with the help of this Scotty dog decapitation sign. So in this situation, we should avoid the extension exercise. And actually, when we are giving rehabilitation, we should follow the principle Mritpindadaranam, Levanamindadaranam, and Pashanamindadaranam explained in Hastadalabhagam. Actually, it is active use and exercise against resistance, and active use and exercise with weight bearing. So the initial exercise, it is better to advise isometric exercise without much movement. The second phase, we can opt with movements, and the third phase, we can give strengthening. So this bridge or pelvic lift or Sedu Mandhasanam can be advised for spondylolisthesis. This is actually abdominal bracing. This abdominal bracing can be done. You can simply do in sitting position, lying position, and standing position. Just tuck in the abdomen. You can do this now itself. Just tuck in the abdomen and hold it for 5 seconds. You can feel the paraspinal strengthening. So this exercise can be advised to almost all patients who are continuously sitting. So this abdominal bracing exercise is very effective, and gluteal stretch exercise, tightening of gluteus muscle can be advised. This abdominal bracing and gluteal stretch can be advised in the very beginning. Knee chest position or Pavana Muktasana can be advised. Straight leg raising or Merudandasana can be advised. But when we are advising this exercise, there won't be pain while doing this exercise. One of the most important thing regarding rehabilitation exercises is patient should not feel any pain while doing the rehabilitation and after the rehabilitation. So after getting rid of this pain, we should opt this rehabilitation. And one of the most important thing I need to tell you regarding spondylolisthesis, the most effective technique is Snehavanam. Snehavanam with Dhanudaram Thailam will be much effective in a spondylolisthesis case after correcting the acne. If it is not possible to do Acha Snehavana, if we are doing Acha Snehavana, it is better to opt Vasti after Acha Snehavana. And if it is not possible to do Acha Snehavana, we can give Shamana Snehavana. And if we are opting Shamana Snehavana, acne should be corrected initially. And after doing the Dukshana initially, we should do internal Shamana Snehavana internally. And whenever we are using Shamana Snehavana, whenever we are doing Shamana Snehavana, we should give this Sneha at the time of appetite. When the patient feels again appetite, at that time the patient can take food. So this is regarding the spondylolisthesis. And coming to another situation, there is radiating pain to right lower limb with pain and numbness. And the tenderness is elicited 3 centimeter lateral to the spinous process. Age of the patient is 55. And I already advised this picture should not be forgot. Why? Because we should always think about the facet joint arthropathy. And I need to tell you this spondylosis, facet joint arthropathy, everything starts almost together. So in this situation, it is better to do Tikta Rasa Grada internally, or we can do Shiravasti, everything at proper time. After getting rid of the pain, actually there will be morning stiffness, night pain. At that time, we need to give internally Amabhajana, and whenever the patient tells us, now my morning stiffness is reduced, I have mechanical pain, I have exertional pain, then at that time we need to switch to next medication. And at that time we can start rehabilitation also. And timely this Tikta Rasa Grada internally. In all these situations, there is no need to go for Gugulu Tiktaga. We can give Tiktaga, Mahatiktaga, Panja Tiktaga can be selected, and accordingly we can use it. So the initial management should always be Amabhajana and Shofahara. When we are discussing the protocol, we will discuss about some examples or templates regarding the same. So later we should give internal Sneha in large quantity. This is the oblique view X-ray of cervical spine. We go through the oblique view X-ray of lumbar spine when we discussed about the spondylolisthesis. Here we can see this is the oblique view X-ray, and this picture is taken from Adams, Clinical Orthopedics Adams. So here we can see the neural foramen is normal. Here we can see the facet joint also, facet joint. So whenever there is anterior osteophyte formation, it is considered as grade 1 spondylosis. Here you can see this neural foramen is normal, but here the neural foramen is affected. Here there is facet joint arthropathy and posterior osteophyte formation. Whenever there is facet joint arthropathy and posterior osteophyte formation, it is considered as grade 2 and there is neural foramen stenosis, not due to disc prolapse, it is due to facet joint arthropathy and due to postural osteophyte formation of body of vertebra. So we can diagnose this with oblique view X-ray of cervical spine. So coming to the next case, pain over coracoscapular region, we already discussed this case, age is 24, there is history of 4 years, MRI normal study. Now it's very common. Actually, we need to correct the posture. I already explained how much load is there when there is 10-degree flexion, 20-degree flexion. So this rehabilitation chin tuck is found to be effective. We can do the tuck in the chin, hold it for 3 seconds. We can do a cervical flexor stretch like this, and all extension exercises like Dhanurasana, Chakrasana, Bhujangasana, it will be effective for this. And we need to correct the posture also. Posture correction is very important. And those who are hearing me, some of you may use mobile. I think a lot of people are not using mobile. Most people, those who are using mobile should do these exercises regularly to avoid early spondylosis, early disc disease. So coming to the next case, in the early phases of Tachner disease, actually we need to correct the posture and rehabilitation only. In the late phases of Tachner disease, we need to give internal medication and we should emphasize more on postural correction and rehabilitation. With postural correction alone, there won't be any change, and with rehabilitation alone, there won't be any change. Each and everything, just like a tripod, we should correct the posture, we should give rehabilitation, and we should give internal medication if it's a chronic situation. And there is pain over right dimple radiating up to the knee joint. There is no pain below knee joint. This is the typical feature, and there will be more stiffness. And actually, it is related to the evolution also. Why? Because actually, the head should, when during normal delivery, if the head should come through this pelvis, then the ligaments of the sacroiliac joint should be lax. So it will happen normally just before delivery. Even if it was a LSES, actually that ligaments will be lax. Ligaments will be lax due to that hormonal change. So from the 56th day to 90th day, definitely after normal delivery, they should do some rehabilitation exercise for sacroiliac joint. If it is not done, after when they start all the normal activities, definitely there will be sacroiliitis or sacroiliac joint synovitis. Most probably it won't be diagnosed. I have some cases which came to me after many months with severe pain and swelling over that particular area, but it won't radiate below the knee joint. So in these situations, active SLR will be positive. Active SLR will be positive. We need to take the X-ray pelvis with both hip AP view. Pelvis with both hip AP view. And we need to see the changes of sacroiliitis in X-ray. It takes some time. So here we can see the normal joint space. Here it is fused. So whenever a patient whose age is in between 16 and 25, male patient who has severe morning stiffness lasting for half hour or more than half hour, with pain or sacroiliac joint come to us, we need to rule out ankylosing spondylitis. Early diagnosis is very important. Age of the patient, male patient, in between the age of 16 and 25 or in between 20 to 30. We need to rule out the ankylosing spondylitis. We need to do the clinical examination. We need to check the Schauber's sign, in which we need to mark the dimple of Venus. We should measure 10 centimeter above and 5 centimeter below, and ask the patient to do lumbar flexion. This 15 centimeter should be above 20 centimeter on lumbar flexion. If it is below 20 centimeter, then the lumbar flexion is affected. So ankylosing spondylitis, we need to do clinical examination more than investigations. Why? Because HLA-B27 might not be positive in all cases. So we need to do clinical examination. And here, ankylosing spondylitis actually starts from the fusion of the SI joint and then it moves upward. So early diagnosis is very important in maintaining the quality of life and life expectancy. So there are some clinical examinations which we can use: flexion, abduction, and external rotation, thumb handle test, anterior and posterior gapping. Actually, in an acute situation of sacroiliac ligament sprain also, which we discussed as the first case, in that situation also this anterior gapping and posterior gapping, the iliac compression test or squish test, all are same. It will help us to rule out whether there is a ligament sprain. So here, this clinical examination test can be done. Palm handle is actually flexion of the hip and knee towards the opposite shoulder, which reveals the sacroiliitis. And in sacroiliitis, so in each and every situation, in a disc prolapse, in a muscle strain, in piriformis, in ligament sprain, or in sacroiliac joint synovitis, each and every situation we can make difference in the rehabilitation. Actually, this position is known as 90-90 position. Hip and knee is flexed. Actually, this 90-90 position is effective as in the initial phase of sacroiliac joint synovitis. In an acute ligament sprain of sacroiliac joint, we should do the immobilization, and after the pain relief, we should do this rehabilitation exercise. 10 minutes is effective. As the patient to keep a mat in between the floor, and it should be in 90-90 position. We should ensure the position and teach the patient how to do it. After the initial pain management with internal medication and with 90-90 position, isometric knee push exercise can be advised. Isometric knee push exercise can be advised in two ways. Actually, this is flexion of hip and knee joint. Ask the patient to do hip extension and prevent that movement, isometric exercise. And ask the patient to do again flexion of hip joint. It can also be resisted with the hand. So this exercise is very, very effective. You can also check this exercise. I already advised you to do the abdominal bracing in sitting position. Just like that, immediately after the class, you may just do this exercise, isometric knee push, and feel how much strength is we are getting for sacroiliac joint, and this is effective. And we can ask the patient to do these exercises, bird dog position. So this is found to be effective. And this is very, very important in sacroiliitis, sacroiliac joint synovitis, to avoid recurrence. To avoid recurrence, actually, uneven weight bearing. Uneven weight bearing is one of the most important reasons for sacroiliitis. So it is better to avoid crossing legs in sitting position. When standing or in any position, sitting position, we are weight bearing on one hip. Actually, that is one of the reasons for when we are standing with the support of a wall, it may cause sacroiliitis. So always be in normal position in sitting position and standing position. So actually we can do a marma, that means in radiculopathy patients, to stretch the QL, the patient should be in prone position, and then ask the patient to go, be in a convex position. If the patient is in prone position, and if the patient has a right lumbar radiculopathy, the head of the patient should move towards the left side, lower limb also towards left side for stretching the QL. It can be done in prone position first, then on standing position it can be done. In the next phase, it can be done along with side plank also, based on the strength of the patient. Stretching of the QL. And in sacroiliitis patient, it is better to move using our thumb. We can move towards clockwise rotation and anti-clockwise rotation over the nimble of Venus. So this is found to be effective to get immediate pain relief. But please note, it is contraindicated in acute injury, and it is contraindicated in systemic illness. Each and every procedure we need to make SOP like this. It should be avoided. Some situations it should be avoided. Some contraindicated situations will be there. So this marma is found to be effective in sacroiliitis and radiculopathy. Both are different. And next case is there is severe aching pain towards the upper limb, right upper limb, and patient supports his right hand in abducted position. This is the position. Actually, one of the differential diagnosis of this situation is inferior dislocation of shoulder or subglenoid dislocation of shoulder, in which patient enters the OPD. The attitude of the patient is supports his affected hand with opposite hand in this position, in abducted position. In same position, the patient will come to OPD the patient is unable to keep the hand in normal position, arm in normal position due to the pull of dura mater. Actually, it is a case of extrusion. And this is very tough to manage this case. Why? Because in lumbar extrusion, if the patient take rest, there will be pain relief. But in cervical extrusion, patient cannot lie down, patient cannot sit. If we need to do traction, it should be in sitting position. So I need to ask you one question. Which one is extrusion? B, C, or D? Which one is extrusion? B, C, or D? First one, A is normal disc. I am asking about extrusion. Actually, B is protrusion, C is sequestration, D is extrusion. And here you can see there is cephalic migration too. Cephalic migration too. So we know about cervical static rehabilitation, and this cervical radiculopathy case, what we followed was we done the SandhiVeda from Shiprasya Dungulopari. Shiprasya Dungulopari. Actually, it is explained in Charakam Chikilsa. In cervical radiculopathy, we are doing the SandhiVeda from Shiprasya Dungulopari, and there is one modification. If there is actually C5 nerve lesion, C4, C5 radiculopathy is there, we can do the SandhiVeda from medial cubital vein, but if there is CC7, then we need to do the SandhiVeda from Shiprasya Dungulopari. If we don't get vein from there, Shiprasya Dungulopari, we can do the SandhiVeda from nearby vein. So it is found to be effective in cervical radiculopathy. And in cervical radiculopathy, based on, we will discuss about the selection of drugs when we discuss about the protocol, and we need to give this rehabilitation. And after the immediate pain relief, initial pain relief, we can opt nasiectomy. Actually, the rehabilitation exercise, cervical static exercise, then we can give scapular stabilization exercise, extension exercise are found to be effective, but in spinal canal stenosis below 10 mm, we should avoid extension exercise. In spinal canal stenosis below 10 mm, we should avoid extension exercise. So this is a protocol which we are following in a pathological situation. In acute injury situation, when we discussed about the transverse process fracture of multiple lumbar vertebrae due to inviolate muscle contraction and T12 fracture, compression fracture, when we discussed about that compression T12 fracture, we discussed the medicine which we are using in an acute injury situation. Actually, this is the protocol which we are using in a pathological situation. The initial phase should be always amapajana, and then before starting internal sneha, we should opt a transitional phase, and after internal sneha, we should give internally rasayana, and this internal rasayana should always based on which structure or which dhatu is affected. Rehabilitation should be advised after amapajana. If you advise rehabilitation before amapajana, some patients will tell, I went to an orthopedic surgeon, he gave me NSAIDs and started physiotherapy. It aggravates my situation, so I came here. Actually, the rehabilitation before amapajana will aggravate the situation. So patient will tell us, I already explained when we are taking the history, actually patient will tell us what are the relieving factors and what are the aggravating factors. So this rehabilitation should be started after amapajana. We should advise rehabilitation in each and every situation. Why? Because patient is taking rest due to the severe pain. To coming back to normal, we should give rehabilitation. And to avoid recurrence, our tools are internal sneha, rasayana, and rehabilitation. If the patient need to continue the activities which they are doing before, patient need to continue the same, we should opt internal sneha, rasayana, and rehabilitation for the better functional outcome to avoid the recurrence. And for Shuddha Chikitsa means to avoid recurrence. And when we are managing, the patient should not be affected with any other discomfort or disease. In that situation, we need to opt this. And actually, this transitional phase is to check the Upashaya, whether it's possible to give internal sneha. And when we come to the Tristuna in management, it is actually Pathya, medicine, and Vyayama. And this Pathya is the relieving factors and aggravating factors of that particular patient. In this we can see a 33% equal distribution in these three situations. In some situations, Patti itself gives 50%. That means in postural correction. In some situations, Vyayama is found to be effective. In some situation, medicine have upper hand. And Tristuna to avoid recurrence is Vyayama, Rasayana, and internal Sneha. That's actually why I quoted this for soft tissue rheumatism. Soft tissue rheumatism associated with spine. For the soft tissue rheumatism associated with spine, we need to focus on Uttanavadarakta Chikitsa. So this actually, I need to tell you my gurus, Matthew Swembali sir, Shyamushran sir, Jos Paikada sir, Ramuti Vaidit sir, and Suresh sir, actually Chandra Umar sir. A lot of my gurus helped me to do my clinical practice and also what I am doing now. And this in this class also, I quoted them in many ways. So this special yoga was advised by Ramuti Vaidit sir and Jos Paikada sir. Actually, this is a modification of Sahajaradi. Just I need to tell the permutation and combination only when we are adding. Actually, Sahajaradi is a medicine with 6:4:2 ratio. When we are adding another medicine, we can make the ratio to 4:4:2:2. Actually, the adding medicine is 4, Sahajaradi is 4, other two are 2:2. Devadaru and Vishwa is 2:2. Actually, this Adari can be used in Radicular situation. We can add Bella when there is weakness. We can add Punarnava when there is Sacroiliitis. Actually, there is a medicine known as Patyadi. The only difference from Amardotharam is from Amardotharam, actually that Haridiki is taken and Devadaru and then Punarnava is added in Patyadi in Ashtanga Hridaya Chikitsa. So we can add such medicines when there is we need to get Shafahara. So this Punarnava is added in Sacroiliitis. In spinal canal stenosis, Dhanvayasha is effective. In all stenosis, in entrapment neuropathies also, this Dhanvayasha is found to be effective as per Jos Paikada sir. In faces joint arthropathy, Rashna can be added, and if there is constipation, Haridiki can be added. So this is actually only an example which we can opt when we are giving that means Kashaya Churna, then we can do this permutation and combination for better outcome. So we can reduce the cost, we can reduce the time, we can reduce the cost, and we can maintain good relief within a short span of time. So I need to tell you the phase 1, phase 2, phase 3 internal medication, some examples. Actually, in phase 1 situation, if we need to get Kafahara Chikitsa, we can opt this Ashtavarga, Dasna Shundyadi. Dashamulama Dasna Panchakam. I am telling only some examples. In this situation, to get rid of Kafavarda situation, to get Amapajana, in the initial phase, we can opt this. And in phase 1, we need to get Pitta Shavana. We can give Pajana Amrda to get the Tikta Pajana and Amardotara for Kadu Pajana. In phase 2 situation, to get Vada Pitta Hara, we can give internally the Anudara Kashaya, Vidaryadi Kashaya, Prasaranyadi Kashaya. And if there is not much pain relief after the initial management within a period of 3 days to 14 days or 1 week to 2 weeks, if needed situation, we can opt Anushastra. And regarding Anushastra also, I will tell a protocol which was advised to me by Ravishankar Parvajay sir, Jomat sir, Shyamushan sir, and Matthew Swembali sir when I prepared for a Anushastra in sports medicine for AVP Coimbatore. Actually, it was in 2021. And for last 4 years, I am following the same protocol. I will tell that protocol of Anushastra to be followed here. And in the last phase, we can opt Dhanvantaram Thailam internally. I am telling internal medication. Dhanvantaram Thailam internally for getting motor power. Shirabala internally for better sensory perception. Sahajaradi in neurovascular diseases. We can opt Maharaja Prasarani in more neurological situations. Rasa Daila can be advised in muscle wasting internally. If there is muscle wasting, we can give internally Rasathaila. These are some examples only. And Rasayana can be opted. I already advised in Asti and Asti related Ubadados. We can give internally Gandhadaila or Krishnadila. We can add Trifala with Gandhadaila. We can add Tila and Amaliki. We can give internally Mamsarasa. So if we need to get much more importance to Asti, when we are preparing Mamsarasa, we should take Asti itself, of which if we are taking a god, we should more focus on Asti. And if we need to get much more importance to the soft tissues, muscles, tendons, and fascia, we should prepare this Mamsarasa with more flesh other than bone. So we can select accordingly when we are preparing Mamsarasa. So coming to Anushastra, I only telling about the basics. If we need to get relief in deeper structures, in lumbar radiculopathy, in cervical radiculopathy, we should give snigdha here. Snigdha here. In soft tissue rheumatism, if there is not much relief, even after internal medication for 2 to 3 weeks, we can do Ruksha here. So this is one basic difference. Here we should opt snigdha here. Coming to Rekta Moksha, actually, in more Pitta Rekta Koba, we should opt Jaluga. In some soft tissue rheumatism, repetitive strain injuries, this Jaluga has much more effect than any other Anushastra. Actually, it came from a lot of case studies in which I am a visiting consultant at Wembley Hospital on every Fridays. We have a good discussion, Matthew Sir and me have a good discussion regarding this Anushastra in each and every situation. And then we came to do Jaluga in some situations. And one thing I need to tell, if we need to get a relief in 12 angula and 18 angula, that means a single tender point. Sometimes patient will show finger sign or palm sign. In this situation, in finger sign and palm sign, we can opt this Sringa or Alabu. Sringa or Alabu. If we need to get result in 24 angula, one hasta, we need to opt Jaluga. Jaluga is the right choice. And actually, it is not based on any people. It is based on the Susruta Sharira 8th chapter Tika. Susruta Sharira 8th chapter Tika, and it is also explained in Ashtanga Hridaya Sutra 38th chapter. So if we need to get relief above one hasta, above 24 angula, we need to opt SandhiVeda. If there is radiculopathy, if there is lumbar radiculopathy, we need to give SandhiVeda on Andhara Andhara Gulfiradare. If there is cervical radiculopathy, we need to give SandhiVeda from Chiprasidangulobari. So this is a basic difference we can opt regarding Anushastra. And Lakham Vedana Shandal Vyadriveka Parishya Samik Visravide Lingam Prasado Manasasada. Actually, this Mana Prasadam can be seen after SandhiVeda. After doing marma also, we can see this Mana Prasada. Immediate relief will be there. And this is another perspective. This is from Susrutam Sutram, 14th chapter. And this, as we all know, Shidoshna Shinkaru Shadai, Upakrandashi Agada, Samik Sadya, Nasidindi, Tekta Jamsa Vivaveda. It is from Charagam Sutram, Vidishon, 24th chapter. And whenever there is Rektaja Roga, we need to opt for things. One is Rektavita Harikriya, second one is Viragam, third one is Ubhavasam, and last one is SandhiVeda or Rektamoksha. Rektamoksha can be done. Now, in Rekta or the Vada Prakopa, we can see we can opt in Rekta or the Vada Prakopa. To get rid of that Rekta or the Vada Prakopa, we can opt this SandhiVeda or Rektamoksha. And one thing in Rekta or the Vada Prakopa, Sparshadvesha or Tokmam Sandaryo Ruja. Sparshadvesha or Tokmam Sandaryo Ruja is the indication. And whenever there is Sparshadvesha tenderness, apart from injury or fracture, we can do this SandhiVeda. This is regarding Agni Arma, Snava Sandhi Sira Prapte Snehadaho Banahanam. So whenever we are doing Agni Arma, never do Agni Arma without Amavajana. So I explained we are following Anushastra not in the initial situation. In some situations where we need to get relief immediately, like sports injuries, and in another situation, if it is not responding after 1 to 2 weeks of internal medication, we should opt Anushastra. And whenever we are doing Nirma, we should do either Leba or Ubanaha. In that situation also, in soft tissue rheumatism situations of spine, we can opt the Leba advised in Uttana Vadarekta. And second thing, we need to do Agni Arma after Leba or Banaha. And after Agni Arma, we should give internal Sneha to avoid recurrence. And one of the most important external application which is very found to be effective in lumbar radiculopathy and which is much more cheap is Avagaha. And whenever we are giving Avagaha, it should be given for a period of minimum 5 minutes and maximum 10 minutes. Just like exercise, just like food. If we take food in more quantity, it causes harm. Just like Avagaha for 20 minutes or 30 minutes also cause harm. Whenever there is sweat in face, we should stop Avagaha. And Avagaha for timely, effective management for 7.5 minutes, it is very found to be effective, just like SandhiVeda. Just like SandhiVeda of lumbar radiculopathy, one patient came to me with severe radicular pain. Actually, one orthopedician referred him for neurosurgeon for surgical management. He came to me in 2018 for another pathology of shoulder. At the time of that flood, he was a volunteer and he met with the injury of shoulder joint and he came to me in 2018. So in 2019, when he had severe lumbar radiculopathy, he went to an orthopedic surgeon and this orthopedic surgeon referred him for neurosurgeon. On the way, he came for a second opinion and I asked him to wait for 7 days. And I gave internal medication. Actually, I give internally Nirgundi, Eranda, Koranda, Bella Vilway, 5 medications. And then I advised him to do Avagaha also, Avagaha, with the help of someone. He need to sit in a sisbath tub with Vadahara Patra and Lavana. And actually, after 1 week, he came and I asked him whether you need to follow surgical management, you can go. At that time, he and his friend told me, actually, there was much pain relief on doing this Avagaha and internal medication, so we are ready to wait. And we managed that case. On the same day, we done SandhiVeda for him. Actually, now also he's under my we are seeing regularly, that I need to tell you, because he come with some other cases to my OPD and he's doing all strenuous activities, including tug of war. So it is possible to manage such cases without surgical management. I think we have good prognosis in almost 70 to 80% of cases where surgery is advised. But 10 to 20% cases need surgical management. As per my practice, actually 100% is not possible. I think, I don't know. I think some of our gurus have 100% relief, but based on my clinical practice, I am telling almost 66 to 80% relief. We can avoid surgical management and the patient can continue all activities based on the lifestyle modification, activity modification, and rehabilitation. So this is the basics of rehabilitation regarding Mrtpinda, Lavanapinda, Pashanapinda Dharanam, active use and exercise against resistance, and active use and exercise with weight bearing. And this Ubanaham Dhara and Vyayama is for acute injury. For acute injury, after the removal of bandage, if there is swelling and stiffness, we can do Ubanaha. In that condition, we can opt Nagaravi. And then we can do Dhara. Actually, this is for functional outcome rehabilitation, and we can do Vyayam also. So when we are doing rehabilitation, we are giving strength to anterior longitudinal ligament, postural longitudinal ligament, ligamentum flavum, supraspinous ligaments, and interspinous ligaments. The entire structure is getting benefited when we are giving rehabilitation, and the patient can continue all normal routine activities. So Sedubandhasanam, pelvic lift, Pavanamuktasanam or knee chest posture, Shalabhasanam, or we can do the alternate raising of one hand and one leg simultaneously. So this rehabilitation is found to be effective. Extension exercise is the most effective exercise, but rehabilitation should also be customized. And in listhesis and in spinal canal stenosis below 10 mm, extension exercise should be avoided. And each and every extension exercise should be customized based on the patient's age, health, and what is the condition of the patient. And we should ask the patient to start rehabilitation padam. Few exercises should be started initially. All exercise should not be started together. And it is better to follow only minimum 10 number to 20 number. Actually, the effectiveness, you can see some studies, research studies. The effectiveness of 10 to 20 numbers and 50 to 100 numbers are same. So it is better to follow 10 to 20 numbers. And the message is Never do massage in an acute injury. It will affect the hematoma. So it will affect the healing also. Never do hot application in an acute injury. Shida Prayoga is to be advised as per Susruda. And never do bandage in an old injury. Never forget to advise rehabilitation in musculoskeletal patients timely. And never do external application in contraindicated situations. And in an old injury, if we do bandage, again, we are harming that patient by because there is chance of muscle wasting. So coming to the red flag, we already discussed if the patient is unable to lie down and sleep, it may be either inflammatory, infective, or neoplastic pathology. We should need workup. So these are the red flags. And we should know about this intradiscal pressure. Only thing I need to tell you, always advise the patient to do knee flexion other than lumbar flexion to take something from the floor. So see this one, the patient is doing lumbar flexion in standing position and sitting position. Sitting position is posing more harm. In sitting position, taking weight in lumbar flexion is more harm than in standing position. So advise this to patient, and based on the patient's job, IT professional or doing job in bank, we should advise the eyes should be on same level with the monitor, and the elbow and wrist should be in free support with back, and always the leg should be touching the ground. So the hip, upper trunk and lower trunk should not be below 90 degree. So we should advise this position. The chin should be tucked in this position, just like when we are looking the head with the shoulder, it should be in normal alignment like this. So we should advise this to patient. So today we discussed about a sudden giving way. We discussed 4 situations. One is disc prolapse. Second one is annular fiber tear. The third one is muscle strain, and last one is ligament sprain. And vertical compression fracture, we can do either a Vibandha Bandha, or we can advise thoracal lumbosacral corset. Then we discussed about prolapsed intervertebral disc, how to diagnose it with flip test, SLR, Sparling test. Then we discussed about transverse process fracture of multiple lumbar vertebrae due to indirect muscle contraction, in which we can use a hip spica bandage or LS corset. Discussed about spondylolisthesis, in which we avoid extension exercise, and we should give internal snehabana for listhesis, followed by we should follow the Vasti. In sacroiliitis, we discussed about some other exercise, 90-90 position and isometric knee push exercise. And in sacroiliitis, internally, Dashamulam, Rasna Panjakam, and the Sindhu Ararandam is found to be effective in the initial phase. Actually, in that situation, in morning, it is better to give Gandharva Hastadi internally, and in evening, Dashamulam, Rasna Panjakam, and Sindhu Ararandam is found to be effective in such situations. These are only some examples. There are a lot of options we have, but the diagnosis we should always be focused. And sacroiliitis in younger age group male patient, we should always think about the chance of ankylosing spondylitis. It is not much common, but never miss the diagnosis. Early diagnosis will help the patient to maintain the quality of life and life expectancy. And we discussed about Merudandasana or straight leg raising, pelvic lift or Sedumandasana, Bhujangasana or cobra posture, sacroiliac ligament strengthening, we have already discussed. For piriformis strengthening, actually the piriformis, we can diagnose it with flexion, adduction, and internal rotation. And in piriformis, gluteal stretch is found to be effective. Piriformis stretch is also very effective in piriformis. Actually, in piriformis, it is better to do avagaham, and there is a piriformis stretch which is found to be very effective in piriformis. The diagnosis is very important. We should know about the differential diagnosis properly, common differential diagnosis. And Pathya is based on each and every situation, and it should be customized. The relieving factors of that patient is found to be effective as Pathya, and the aggravating factors of that patient should be Apathya. And this Kerala traditional low cost yogas, we discussed about some examples which are the drugs are either 3 or maximum 7 or 8. These drugs are found to be effective, and the medicine which low number of drugs we get that medicine, and the Kerala medicines which are seen across Kerala is found to be effective. We should reduce the number of drugs in a kashaya, which will be more beneficial than a kashaya with much more drugs. And anushastra should be opted based on the situation. We are not using anushastra in each and every situation. If it is not responding, after a while we can use this anushastra as part of pain relief. We can use these procedures. Internal sneha, rasayana, and rehabilitation should be advised to all patients. In cervical pathology, just like Rachna Shudyadi, in Radicular situation, Dhanada Nayanadi is also found to be much effective. So our strengths are internal sneha and rasayana. Our opportunities include marma, anushastra, and bandage. We are avoiding marma in acute situations. So we can overcome the weakness and threat with our strength and opportunities. So just like the funnel of introduction from applied anatomy to Chikitsa. So we should always evolve, refine, and update. Sadada Dhyanam is much more important in maintaining the quality. Alabdasya Labho Yoga and Labdasya Paripalanam Shema. To get a new knowledge, we should make some efforts, and to maintain that knowledge again, we need to maintain the same efforts. And most important thing is to be humane. And if we are following this principle, then we can always evolve. And how to evolve? The answer, this was by Tinul Parsar: learn, teach, and write. So one of the most important thing I need to tell you is always document with patient reported outcome measures with neck disability index in cervical cases and oswestry low back index with for low back patients. We should follow the patient reported outcome measure. Why? Because before MRI and after MRI, there won't be much difference in all cases. In disc prolapse situations, we can see the difference after a period of 6 months. We can see there is natural shrinkage and fibrosis of the disc, but we can follow the patient reported outcome measure and start publication in indexed journals. Then definitely it is the answer for all the criticism against Ayurveda. And also, when we start to document one case, when we start to publish one case, we are much more familiar with that case. So always try to write, publish for us and for Ayurveda. So this is the last message. I am thankful to my Guru Shyamushtan sir for this message. Actually, Srudadanyatra Sandushtam Tatraiva Chakuduhili is from Ashtanga Sangraham Satvurtam. Be contented with everything except knowledge. Actually, we are contented with our knowledge and not contented with all other things. So never be contented with our diagnosis, present diagnosis. Never be contented with our present protocol. These two things are actually a quality of a Vaidya. Never be contented with our present diagnosis and never be contented with our present protocol is the quality of a Vaidya, and never be contented with our knowledge and be contented with all other things. Be grateful to all other things. And actually, this is the advertisement of Indian Navy, an ocean of opportunities. And discover your strength, design your destiny. Actually, we need to focus on only a few things. And actually, all of us know him. He took almost 20 or 24 years effort to run in entire Olympics in below time for 2 minutes. Actually, calculate his time in his entire Olympics. Actually, he ran below 2 minutes. For that, he took almost 20 or 24 years to become a superhuman. Once again, I am very much thankful to the organizers for this opportunity to share my thoughts regarding low back pain or spinal disorders. Once again, thank you for your patient listening. Thank you.
Wonderful. We have few questions to discuss. Before that, I would like to, call Dr. Rahul Panayan to give a brief on KAL. Dr. Rahul, please.
Thank you, sir. Thank you, doctor, for the wonderful presentation. And I would like to introduce few of the KL products that will definitely help your daily practice. As you know, Kerala Ayurveda is having an 80 years of legacy, and we are manufacturing 300 plus classical and 100 plus patented formulations. And we are the pioneers of proprietary Ayurveda medicines in Kerala and innovators of Gridam capsulization. And also, we are the first Indian company to secure a US patent for a unique herbal Ayurvedic combination. And we are also GMP and ISO 9001 2015 certified. And we are the most awarded Ayurveda company in the Ayurveda industry. And we have a comprehensive ecosystem containing products, academics, clinics, hospitals, resorts, and export. And we have a herbal garden with 1,200 plus medicinal plant species, and also respected as the most ethical and trusted name among doctors. Thank you, doctors, for your trust. And enter into the few of the flagship brands of KL. Cervical Tamarthi soft gel capsule. It is a Tilatailam based capsule containing three remarkable yogas in a single capsule form, containing Dhanyamlam, Kubjaprasarani Thailam, Ketaki Muladi Thailam. And you know, the Dhanyamlam is a well-known anti-inflammatory combination, and it containing Kubjaprasarani Thailam, that is a rare yoga from Vaishiji Ratnavali, and it is specifically indicated for Kaphavada Vyadis and Griva Stamba. And also this containing Ketaki Muladi Thailam, this is a special yoga for Astigata Vada, and it is a 3-avarti combination. And you can see the indication of Kubjaprasarani Thailam specifically as Hanu Prishta Shiro Grivastambam Chashuni. The Grivastambam is specifically indicated in this yogas, and also it is very good for the Kaphavada Vyadis, explained in the Vaishiji Ratnavali. And also Kediki Muladi Thailam, the yoga, you can see that it is for the Maruta Mastigadam Vinihandi, Astigata Vada, or can be used in degenerative conditions as well. And it is a 3 times potentiated Avarti capsules to ensure maximum efficacy, and it helps to manage inflammatory and degenerative conditions, and also effective in cervical spondylitis, and also relieves the cervical radiculopathy. And along with that, we relaunched a classical formulation that is from Sahasra Yogam, Rasna Shundyadi Kashayam. Already Dr. Jikusa has explained, can be used in the initial stages. Rasna Shundyadi Kashayam is a rare yogam from Sahasra Yogam, containing around 22 ingredients: Rasna Shundi Guduji Sahajara, Jalada Abiru Patya Shadahui, Tikta Kachura, Vasha Anilapasayade Panchamula Dhoyena, Ebirdravye Kashaya, Twiridamahere, Pidamatra Prabhava, and it is specifically indicated for Manya Stamba, Andhra Vrdhi, Jwara Pitaka Kadi, Sandhi Sarvanga Pida. Even though it is explained in the Jwara Pragrana, it has an indication of Manya Stamba. And in Kafavrta Vada, it has an excellent action, Rasna Shundyadi Kashayam. And another flagship brand from Kerala Ayurveda Limited, that is Lambajust Avarti soft gel capsule. And it is also a yogam from Vaishiji Ratnavali, that is Simhasyadi Kashayam. And the yoga is Simhasya Dandi Kridamala Ganam, Pibet Kashayam, Rubutaila Misram, Yog Rudrasi Nashtagadi Prasuptaha, Sashigratam, Sadhyada Matajda. You can see that the yoga itself saying that it should be taken along with the Rubutailam or Erenda Thailam, and we have added Nirgundi Erendam to this combination, and a 3-avarti capsulization is done. And say Simhasyadi Kashayam plus Nirgundi Erendam combination. It helps to manage inflammatory and degenerative conditions, and also very effective in sciatica, and also helps to relieve the sciatic nerve compression. It is also a potentiated Avarti capsule of 3, and it is very effective in Vridrasi as well as Kadishula. Another one formulation that is very well known, accepted by the doctors, and it is none other than KM Labam or Karutha Marmani Labam. It is explained in Sahasra Yogam, and it is explained as Kudambu for Marmak Shobha. Here you can see the yoga of that particular combination. It is in Malayalam, containing Kuvayural, Kundirikam, Chenni Nayagam, and also we are adding the Karpura also. And it is a modern adaptation of our traditional Karutha Marmani Guliga, and it has a powerful anti-inflammatory action, highly effective for sprains and traumatic injuries, infused with the Karpuram for the superior analgesic release. Simplified Lebanon procedure for effortless application. Here you can see its indication as Marmak Shobangal Poidum. It has an excellent action in traumatic injuries. And next one combination, the last one, the Myaxil oil. It is a combination which we launched in 1994, and it is a 30-year-old brand. And it has the combination containing the ingredients like Devadaru, Rasna, and Nandi Vriksha, along with the eucalyptus and lemongrass oil for a soothing action and deep tissue penetration. And it's providing quick relief from chronic pain, joint stiffness, localized inflammation, and also helps to enhance joint mobility and flexibility. And it is designed for rapid absorption and deep action, ensuring faster relief for patients. And I would like to introduce one of our quarterly journal, and you might be knowing that Kerala Ayurveda Vaidyam, and we started sending it to all the doctors. And to know more about our product services and Vaidyam, please send a mail to Dr. Rahul at keralaayurveda.biz, or you can send a WhatsApp or call to 8281-862-723. I repeat, 8281-862-723. And that is the end of my small presentation. Thank you all for patient listening. Over to Jairaj sir for continuing.
Thank you, Dr. Rahul, for the presentation, bringing the traditional formulation in a modern format for the effective application. Thank you for that. Dr. Giku, we have few questions which we can discuss at this point of time. Okay. So, Namaste, sir, you told the patient to rest on protrusion, extrusion. Rest means supine position or lateral position?
Actually, how much PT rest is needed is based on pain relief. It depends. In protrusion, actually within 7 to 14 days, the patient can start routine activities, and in extrusion, it may take 14 to 21 days. And in that position, actually, supine position is effective. Lateral position is also effective. Prone position is also effective. The world-renowned McKenzie exercise, the first McKenzie 1 exercise is in prone position. So actually, prone position lying in 10 minutes also help the patient to get rid of that pain. So actually, the patient in the very initial phase, actually sometimes only 1 or 2 days rest may be needed. In that situation, the patient can lie down in any position. Actually, in that situation, we should advise the patient to avoid continuous sitting and continuous standing. So that is the basic thing to be followed.
Excellent. Thank you. Another question, sir. In case of L5-S1 central canal stenosis, 7.6 mm, and L4-L5 CC stenosis, 8.5 mm, and indentation on nerve roots, what should not be done as a management? What should not be done as a management? Like you should not do extension.
Actually, in this situation, I need to tell this disc which is prolapsed. Our aim is not to keep it in back normal position. Actually, in this situation, we should always focus on Pakvasheka, the Vadagova Chikitsa. On doing this Pakvasheka, the Vadagova Chikitsa, the patient will be back to normal. And then to avoid the recurrence, we should advise the patient to follow the regular rehabilitation exercise and postural correction. So in this situation, actually extension is a problem. So in that situation also, in the initial phase, in the acute phase, we should avoid this continuous sitting. Such things should be done. And actually, I think in more, I will say when it is actually this situation, canal stenosis below 10 mm, in that situation, that means the contralateral SLR and contralateral flip will be positive. So we should take care, much more take care in such situations. And in that situation, it is better to do internal Snehavana, Acha Snehavana and Vasti than external therapies. So I should prefer on such things in more complicated cases.
Wonderful. Thank you. Best time to use different Eranda thylums?
Actually, in the transitional phase, in the first phase, in Amavasana phase also, we can use Eranda Thaila in very small quantity. Actually, Eranda definitely help us in 2 ways. It acts as a painkiller effect will be there for Eranda. And also it can be used in the initial stage. Whenever there is Ama, we can use Eranda Thaila. So I will prefer whenever we need to get rid of this more Pitta Shamana, it is better to use Eranda Sukumara. Whenever we need to get more Kapha Shamana, we can use Sindhu Eranda or Hingu Trigunam. So based on that, we can select, and whenever we need to give much more importance to Abhana Vayu and Lomana, then we can use Gandharvahasta. So we can prefer based on that. And in the transitional phase, before starting the internal Sneha, in the second phase of transitional phase, we can give this Eranda Thaila 10 drops, 5 ml or 10 ml before starting the internal Sneha. We can check whether it's Supashaya or not. And based on at that time, we can definitely give internal medicine based on the dosha predominance.
Wonderful. Next question. Sir, in case of radiating back pain, when do you prefer Agni Karma over SandhiVeda? And which Dahana, Upakarana and Dravyas are most effective for lumbar or sciatic pain? Also, how frequently should Agni Karma be repeated to achieve sustained pain relief?
Actually, thank you for that question. Agni Karma should not be repeated multiple times. It itself causes degeneration. So all these ancestral procedures which are found to be effective should be done only once with proper Purva Karma and Paschat Karma. Thank you for that question. Then only I can answer this question because it was not told in the presentation. So generally in all soft tissue rheumatism, we should avoid Agni Karma in Pitta Vapa situation. We should opt SandhiVeda or Rakta Moksha. In lumbar or cervical radiculopathy, in the initial phase, we will opt SandhiVeda first. And whenever there is a pointed tenderness, again, on particular area on C5 or C6 or L4 or L5, in that situation, we'll opt this Snigdha Agni Karma. And for that, we are always using Eranda leaves or this Datura Patra leaves, and we will use oil also. Along with that, we will tear these leaves into the oil, and we take that hot leaves, and we will keep inside one large leaf of this Eranda or the Datura and then do it in a fraction of a second. We should take utmost care to avoid Adidagda when we are doing Snigdha Agni Karma. This is the protocol which I am following in this first SandhiVeda and then in needed situations Snigdha Agni Karma. But in soft tissue rheumatism, it is a different perspective, and I'm thankful to Ravishankar Parvaja sir for teaching me this technique.
Wonderful. Thank you. Next question. So what can be the differential diagnosis of hip pain near joint and acetabulum in a patient known case of diabetes since 20 years? What will be the management?
Actually, there are a lot of differential diagnoses will be there. To tell the management, we need to know the diagnosis. So first thing, we need to check the range of motion of hip in prone position, in this sitting position and supine position. Most of the time, most of the hip pathologies may be due to soft tissue rheumatism, repetitive strain injuries. So gluteal tendinitis, then graded prochondritis. There are a lot of differential diagnoses. Ischial bursitis will be there. In some situations, there may be a chance of more complicated situations like avascular necrosis, which is much more common before 4 or 5 years. Because COVID, actually this COVID vaccine and also the steroid which was used to save the life of patient at the time of COVID, actually based on these three things, the prevalence of avascular necrosis is much more common. So we need to check the clinical examination first and come to a conclusion with proper investigations. And then we should, based on the diagnosis, we should opt the management.
Okay. There's an interesting question. If kids are walking on toes always since years, what does it indicate?
Actually, we need to know the diagnosis. Sometimes maybe due to tight Achilles, it may happen. If it is maybe due to tight Achilles, then it is easily manageable. Then in that situation, rehabilitation and external application of our thighs will definitely help that situation. Sometimes it may be due to a pathology related to knee or hip, or maybe due to any lumbar pathology. There may be any developmental anomaly will be there. So we need a thorough clinical examination. And if I have doubt in these situations, I am always referring that patient to a pediatric orthopedician who is practicing at Ernakulam. We have a good rapport with this regular reference he will send a letter to me with the advice and diagnosis. Sometimes the patient should follow modern management itself. In some situations, we can manage the case, and he will send back the patient to us with proper
Okay.
diagnosis. Some situation he will tell in this case we need to correct this with this surgical management.
Wonderful. That's always having the cross referral and able to cross verify. It's always, even here in the California, we have a group of modern doctors and us work together as a team. So great. So now regarding your presentation, there's a question. Sir, please explain one more time about heel walk and toe walk.
Okay. In heel walk and toe walk, we are always checking the power of the patient. Not on heel walk, we are not checking whether there is pain on walking in heel. In heel walk, we are checking the patency of the L4 nerve root. If the patient is able to walk in heel for 10 steps, then the power is 5/5. For S1, we are checking the toe walk. Actually, it will help whether there is weakness. And in cervical spinal canal stenosis also, the patient is unable to do this heel walk and toe walk. So we can ensure that also. So in toe walk, we are checking whether the S1 nerve root is patent. For L5 specifically, we are checking the dorsiflexion of the big toe. We are opposing with our thumb, and we can check both sides together and check whether the L5 nerve root power is 5/5. So heel walk and toe walk is for L4, L5 and L5.
Wonderful, wonderful. Now, it's already time. It's almost 9:50. And I think there are a few comments or questions. We would suggest, since it is time, please bring those questions or comments. This is a series of 3 talks. Please bring any other questions in future. And Dr. Giku, that was a wonderful presentation. The precision and the clarity of your presentation is very inspiring. And the confidence of the cases when you say, that is really a real inspiration for the young doctors. So thank you for inspiring us. Thank you for bringing all this deep clinical knowledge and precision, how to combine this assessment, treatment, based on the avastha and stage. So thank you. See you in the next presentation. We really appreciate your presentation today. Thank you.
Thank you, sir. Good night, sir.
Thank you. Good night. Good night, everyone. Thank you for joining.